Yeah, so the purpose of research in general is to contribute to scientific knowledge, and it's for greater scientific discovery. Research benefits the wider community for the topic that's being studied. So sometimes individuals, depending on the study, may not benefit directly from research participation, but it does benefit the wider community as a whole. And a thing with research is that it's because it takes time to collect data. We're putting together not just our study but other research studies as well, data together, evidence, and put the information out there so that way clinicians and researchers can use this information in their management of the related topic. So for example, with thoracic aortic aneurysm and dissection, the current guidelines that we have for family screening, for surgical intervention, has all come from studies out of our lab as well as other sites across the world. And so this is what the purpose of research is for, and it does not always enact change immediately, but it does contribute to knowledge and impact the medical field, later on down the line. So in our case, like I mentioned, if a big focus is on identifying the genes behind thoracic aortic aneurysm and dissection, we can't always guarantee we're going to identify a gene. So even if you're in the study, we don't find a gene for you, you're still helping because we're learning as much as we can about thoracic aortic aneurysm and dissection. So we're still learning from your medical records, from your experiences, so we can put it together, summarize it, and get more numbers to really put out some powerful data out there in this area.
Sure. So in the John Ritter Research Program, we of course want to welcome as many people as possible, but we are a little bit selective to make sure we're focusing on cases of aortic disease that have a high probability of having a genetic cause. So ultimately, we do this by filtering participants such that they meet one of two criteria for our major study. So first criteria is that you are welcome to participate if you had a thoracic aortic dissection. So this is a dissection in the chest region, typically called a type A or a type B. So if you had that at age 65 or younger. So that is one criteria. If you don't meet that criteria, you can also have or have had a thoracic aneurysm in the aorta with one other family member at least who is also known to have thoracic aortic disease. So that would be a thoracic aneurysm or a thoracic dissection as well. So those are the two circumstances in which we would love to get you enrolled in the study. And again, it's just to ensure we're focusing on and enrolling individuals who have genetically caused disease. So let's say you're in this study and you want to get all your family members enrolled. That is great, but we're also going to be a little selective there as well. In most cases, we would like to enroll all of your family members who are known to also have aortic disease. This is because these individuals are most likely to carry the genetic variant or the genetic marker that is causative for the disease. But this is a really powerful tool because let's say you have aortic disease and we find this rare variant in your DNA. Let's say we have 4 other people in your family with known disease, and we also find this rare variant in them. That's very powerful evidence that might suggest that this sort of variant we found is disease causing. So we love to get everyone enrolled in the family with known aortic disease. Now, sometimes there are exceptions. We sort of go on a case-by-case basis per family. So once your family's enrolled, we'll work with you personally to make sure we get everyone included who might be helpful to the study. But if you have any questions about this, if you even think there's a very small chance you might be eligible, or if you're not sure, please don't hesitate to reach out to us and we'll make sure we get you enrolled if you are eligible, because we don't want to leave behind anyone who could benefit from being in the study.
Sure. So clinical genetic testing is considered diagnostic, and it is or has become a routine part of clinical care for patients with hereditary thoracic aortic aneurysm and dissection. And it is performed in diagnostic certified labs and can be used to inform your or patient's care and management and that of family members. However, genetic testing that is considered clinical or diagnostic can't always give an answer because we haven't identified all of the genes that are responsible for aortic aneurysm and dissection. And that's when research comes into play. So the research offered through the John Ritter Research Program and supported by the John Ritter Foundation offers an opportunity for families who didn't receive an answer through clinical genetic testing to explore through research potentially the underlying genetic cause for their aortic aneurysm or dissection or that of their family members. So because it is research, it is not designed to give a yes or no answer right away. Sometimes it takes years to identify the genetic cause for a family's aortic disease, and it can't be expected that it will provide an answer in a definitive sense that you would typically get from clinical diagnostic testing. Sure. So in contrast, to give some perspective, if your provider orders clinical or diagnostic genetic testing, typically a sample is obtained and sent to the lab, and you would get a result within a month, give or take. And in contrast, when you submit a sample through the John Ritter Research Program to identify, potentially a new unknown cause for aortic aneurysm or dissection, you may not hear back for months, years, if no genetic cause is identified. However, we try to check in with families as new information arises, and certainly we encourage families to contact us if there are any updates in the medical history or family history, because that can be useful information that can help us and facilitate the research moving forward. So it might be that you don't hear back for a while if there is no new information to share, but we welcome recontact, and we do try to check in to get updates from family members periodically.
So I realize it does take a long time. I can go through all the steps and all the things we have to do with your sample to even get some data to begin to look at. And I can also tell you that for some families, in fact, about 40% of the families that have been in our study, we've already given them results. So realize that we are making progress. We haven't been good at communicating that we are finding these genes as we go along. But it takes a while. I think the number one reason why it takes so long is that we now know that there are many, many genes in the human genome that can be altered to cause this disease, and that's called genetic heterogeneity. And so if we go through an individual's DNA, and sequence all the coding regions, or the part of the DNA that tells the cell how to make proteins, and look at that, we find about 300 possibilities as the disease-causing variant in every single individual that we sequence. And so we have to go down and find out of those 300, which one is disease-causing. And that's where it gets difficult when you've got a lot of genes that can cause the same disease. And then the fact is that many of those variants will be benign and won't cause any disease at all. And they will cause us to be a little bit different from each other. And it's all those kind of variants that make us unique. But it does make it very hard to go through the haystack and find the needle, which is the disease causing variant. So we want to have an answer for every single family in our study. We can't promise that, but that's our ultimate goal. As we've been doing, so we've been doing this now for 20 years. We've been collecting families. We're up to over 1,300 families in our study, and that translates into thousands of people. And like I said, 40% of those we've solved. So we still have 60% that we haven't solved. We've identified 20 genes, my group, and then some contribution from other groups. But our calculation is that there's probably 100, 120 more genes that we have to find. So it's just going to take time. For us, the more families that participate in our study, the faster we can move. In families that have multiple members, we still have a lot of families where everybody who's affected has not participated in the study. And for any family, the more people we have from the family that we know are affected, the more power we have to find the disease causing variant out of those 300 variants that are there. So bear with us. And so we hope to get there. We're moving into more and more new technology. We do have a new technology that we just tested, where I think we'll solve another 10% of the cases doing that. And that's where we look at the transcripts instead of the genome and sequence through those. And so, so we're looking for additional things where we can use new and novel ways to find new genes. The other thing that's really going to help us is that there's other people that are now moving, starting to work on the disease. And that is wonderful, because then we can start combining data. Once we have more data, we have more statistical power to find genes. So, and I really want to push that agenda so that everybody who has any data, that we're working as a consortium, and we will do that under the JRF umbrella. And hopefully with a JRF push behind it and the patient push behind it.
How does research differ from, genetic testing ordered by your doctor, or any ancestry genetic testing like 23andMe? They're all three completely separate types of genetic testing. So if you think of like a test in general, there could be physical fitness tests, there could be written tests, there's tests in different topics. It's the same way with all this different genetic testing. So they're different methods. With research, we don't know where we're looking. And so we don't, check a person for every single genetic variant that they carry that can impact their health, because we are focused on our topic. And the clinical genetic testing ordered by a medical provider, this one's diagnostics. This is one that your doctor orders as part of your medical care, and the answer will provide guidance on, how to, proceed with your medical care, and if anything needs to change. This one is done, in a timely manner, because it's part of your healthcare, and the results, are used for your treatment. And then ancestry genetic testing is a different method. And this is because they're looking for common variants shared between people, because you're looking for your ancestors. So you're looking at, what DNA you share with other people. So all of these methods are looking for different genetic markers, and they have different methods of, providing evidence on these genetic variants and how they can or cannot impact your healthcare. So this is because research genetic testing and that clinical genetic testing are different. The clinical genetic testing is ordered based on your features, your symptoms, your family history, and then there's specific guided testing or panels that you can be checked for, based on what's going on with you to see if you carry one of those genes. For research genetic testing, we have to work with individuals that carry the disease in question. So for us, thoracic aortic aneurysms and dissections, because they are the ones who will help us more in finding a causative gene for themselves and their family, because they're the ones most likely to carry the gene. So if we enroll somebody who does not have any aneurysm dissection, we don't know if it's because, if we do testing, we don't know if they didn't inherit a gene from somebody in the family, if they're not, affected, that there's no gene at all, or, if it's something new, we don't have that correlation, like this is a new gene, but this person doesn't have the aneurysm or dissection. So that doesn't contribute to the evidence of linking the gene with the aortic disease. So if somebody wants genetic testing done to see if they carry any of these markers that we already know about, that's why we recommend doing that clinical testing ordered by a medical provider, so that way they can get those answers and talk with a professional who will know their history, because we're just on the research side and we get a small picture of what's going on in the person's health history. So if anybody is ever interested in pursuing clinical genetic testing, they don't know where to start, we at the John Ritter Research Program can also help direct them provide them in that direction in case they would like to pursue that as well as research.
We're not allowed to report negative results. We do end up sequencing all the genes that we know cause thoracic aortic disease. But we don't do that with the sequencing depth or with some other additional more molecular assays that the diagnostic labs do. So we are encouraging everybody that's in the study, if they haven't had genetic testing that has been ordered by their doctors, or if they haven't gone to one of the companies that will let you order genetic testing as a patient, we urge you to do that so that you get the clinical testing of all the genes that we have identified. Because once again, they sequence to a greater depth than we can. If we sequence to that depth, it would cost our research program, 2/3 of the money. So it would really slow us down. So we really want you to do that clinically. And then they look for like big rearrangements in the genome, and we don't really look that carefully for those big rearrangements because because of the type of sequencing we do. So really, please go and get the clinical testing done. A few of our families, out of the 1,300, I can think of 2 that got solved when they had the clinical testing, and it picked up one of those big rearrangements in the DNA that we just can't pick up based on the type of sequencing we do. And that was in one of the known genes. So they moved into our solved category.
Sure. So when we learn through the John Ritter Research Program, through research of new information, say a new finding that we feel is responsible for the aortic disease in the family, we inform the research participants and also inform them that that information needs to be validated and clinical diagnostic research labs. So that's where the clinical testing kind of comes into play. And the reason we recommend that is related to what I mentioned earlier, that it just needs to be confirmed in order for it to be used for care and management. And so once that's done, and that's confirmed, then that information can potentially affect the way that we treat and manage someone who has a diagnosis of an aneurysm or dissection, in terms of how often we're screening, what arteries we're screening, what types of surgical management or treatment options are available to patients. And for family members, because this is considered a hereditary or genetic condition, we can use this genetic information to identify other members in the family who are at risk of developing similar conditions, and hopefully, screen proactively to prevent these aortic dissections from occurring in the first place. Sure. So the results from research have the same potential effects that testing does, from clinical diagnostic testing, which is that genetic information is protected under a law called the Genetic Information Non-Discrimination Act, often referred to as GINA. And essentially that means that information that is obtained through genetic testing can't be used to affect people's health insurance by way of increasing health insurance premiums or dropping from people from their health insurance plans. And there are some nuances and exceptions to that. And one of them relates to life insurance, and the protections under GINA do not apply to life insurance. However, this typically isn't a problem we encounter either with clinical genetic testing results and certainly research results, because most people who have been diagnosed with an aortic aneurysm or dissection, that information is already publicly available or is available in their healthcare record already. And so new research results or new genetic testing results don't really impact that. Additionally, one other aspect related to research results is that through the John Ritter Research Program, when you enroll in the research program, we keep your information confidential, and so that does not become a part of your medical record like it would in other typical testing environments. So we deliver the results to you and other individuals, including your healthcare providers, if you authorize us to do that. But it is really up to you, the research participant, in terms of who you want to share that information with. So if you want to make that part of your medical record or share that information with your providers, that's up to you. But it's not something that we do if you're a participant in the program.
So the research we do here at our research program, although it may not, benefit you, the participant, directly, it can have the potential to benefit the entire community, like, other patients' families, because even if we do not find the causative gene for your thoracic aortic diseases, the data that we collect from each participant will, in the long run, help create novel guidelines in the realm of medical care and also diagnostic procedures for these thoracic aortic diseases. Your enrollment can help other what we call unsolved families, because the more people we have enrolled, the more data we have, the more that helps us in our whole like population of research enrollees. So, when it comes to research programs, particularly in ours, we take the patient confidentiality and like security very seriously. A big component of our research is delving into like the medical records of our patients and kind of looking into their personal information. So we always, just want to make our participants and their families rest their mind at ease that any data we do have of theirs is secure and it's kept on encrypted servers. And when the opportunity does come that we may want to share interesting cases with other qualified institutions or personnel, it's shared in a manner that's de-identified, meaning it's not linked to the patient's name, date of birth, or their address, or any personal sensitive information like that.
Okay.
I think that I think when you have 2 or more members in your family with thoracic aortic disease, there has to be an underlying genetic variant. So it may take us many more years to find it, but like I said, I'm hoping to solve all the families. And so I don't think we'll have many families that fall under that in 10, 20 years from now. But even so, it may inform us that there are some families where there might be something environmentally there that's causing multiple members to have dissections. Like, could it be that your family has a certain type of hypertension that predisposes it to dissection? So we'll probably go back and look at those families very carefully if we can't find the genetic alteration. We are moving from sequencing just the coding regions of the genome. We're now setting up to just take all our families and sequencing the entire genome. So we will have the data that, if it's a genetic trigger that's causing multiple members to have disease, we will have it somewhere in that data. So, and I don't think we understand all the environmental triggers. And that's another thing that we are planning to really push, is getting more information about what were people doing when they had an aortic dissection in particular, and what drugs were they taking? What were they taking over the counter? How much exercise were they doing? Were they smoking? Were they not smoking? And things like that.